Great. So maybe you could just start by saying your name and your title.
Sure. My name's Elizabeth Plimack, and I'm a GU medical oncologist at Fox Chase Cancer Center, where I direct GU clinical research. My interest and focus is in bladder and kidney cancer translational research and clinical trial work.
Great. So can you give me just like a general overview of what you're going to be talking about today at the conference?
Sure. So today I'm part of the upper tract session. So that's looking at upper tract urothelial cancer and issues specific to that subset of urothelial cancer. I was charged with talking about checkpoint inhibition for upper tract urothelial cancer, a topic for which I joke there is no data. So that subset has not been carved out of the larger clinical trials in terms of how that group did relative to the rest of the urothelial cohort. So we don't have any clinical data. Preclinical work has generally been done on panurothelial, not specific to upper tract. So I think there's a big opportunity to really explore this further. What I'll be talking about is just some background on checkpoint inhibition in urothelial cancer, so the data to date that's been presented, and then try to draw a few hypotheses as to what questions might be interesting to look at in terms of upper tract.
Great. I'm just going to close the door.
Oh, sure.
Yeah, the background noise is going to be like picking out the transcriber. So you said this is relatively new.
Well, so checkpoint inhibition is new in general. We just
Right.
saw a couple of trials read out, 2 atezolizumab trials and 1 pembrolizumab trial in urothelial. More are definitely coming, so we're eager to see those at maybe this meeting or future meetings. Urothelial upper tract disease was usually included in these larger trials, which we're happy about, but looking at them as a subset has not been done yet that we've seen. So it'll be an important question to look at going forward.
Okay, so explain to me why that's an important question to look at.
So the biology of upper tract we think is different than bladder urothelial cancer. We're not sure. There are a couple of provocative papers looking at genomic sequencing of upper tract compared to bladder cancer, looking at sort of subset analysis of upper tract compared to bladder cancer. One of the challenges with upper tract is getting enough tissue to do these studies. We can really only get it for those that are resected, and those represent sort of the more aggressive, where you would go in and get the actual kidney or upper tract out. Whereas in bladder cancer, we have opportunities with TURBT samples to really get more tissue. So it's one of the issues that has hampered research into upper tract urothelial specifically. So these studies with checkpoint inhibition, which is the topic of my talk, are all in metastatic disease. So whether it originated in the upper tract or the bladder, those patients are all grouped together. Whether a disease, where it originates really dictates biology once it's metastatic, I don't think we know. And I think some of the other speakers will be touching upon that in their presentations.
So it's relatively early that you're looking at this in this particular...
Well, it's so early that there's no data.
Yeah. So what do you think is the first step that you need to do?
So I think we need to look at the subsets of upper tract in these larger trials, right, as I said, and just see if there's anything that stands out from the group. It may be that they perform just as well in these metastatic trials. I think therapy directed towards upper tract will come after it's better defined in sort of the wider group, right? So if we know it's effective, for instance, neoadjuvant, that would be a place to look for bladder cancer, for adjuvant. And then I think looking, and I'll talk about this, at mutations, mutational burden in cancer in general is going to be very relevant to treatment, both chemotherapy and immunotherapy. And certainly for some upper tract tumors, those associated with Lynch syndrome or certain carcinogens, there is a hypermutation phenotype that may render those tumors more susceptible to immunotherapy. And so in my talk, I'll sort of pull from the literature and other tumor types to make that case as a hypothesis that's worth testing.
So in this particular location, is bladder cancer more prevalent? Are there more cases?
It's more rare.
It's
so
more
upper
rare.
tract urothelial is a more rare entity than urothelial bladder cancer.
But it is distinct. I mean, there's a different sort of set of...
We think we're trying to define how it's distinct. I don't think we know. I mean, for instance, Lynch syndrome, which is a DNA repair defect syndrome, a genetically heritable syndrome, results in more upper tract urothelial cancers than bladder. And so there's obviously a biology at play there. We don't know quite what it is that makes it separate. Dr. Rupre will be talking about that in his talk. I don't know if you're speaking to him, but he'll have some comments along those lines. So
Okay.
We'll
Great.
see. We're still learning.
Right.
Yeah.
So let's take a a different tack now. So, you know, there's been a lot of talk about immunotherapy and bladder cancer. You know, it's been like 30 years since a new treatment's been available. So what is this, like we're on the doorstep of something here?
Yeah, I mean, I think we're just now seeing phase 1 and phase 2 trials read out. I think it's worthwhile based on what we're seeing, for instance, in the atezolizumab data that Jonathan Rosenberg presented at ESMO and that Gene Hoffman is going to present tomorrow or Friday, this week at this meeting. You know, it's very compelling. It's very compelling data. It was a large data set. It was done on a lot of patients, but it wasn't a randomized controlled trial. And so I think to solidify those findings and sort of get us comfortable with the fact that, you know, okay, what we're seeing is a real benefit to patients, we look to the phase 3 trials, which are ongoing currently.
Now, are you doing any research on your own, or do you want to talk a little bit about that?
Yeah, so my research, my own research is in biomarkers of response to chemotherapy, and so we published on that, and we're still working on that question. We did find a DNA repair defect signature in 2 neoadjuvant subsets that validated, and so we think that that's real and is going to be useful in terms of guiding therapy. We're doing 2 trials at our center looking at whether we can find those patients who are so sensitive to neoadjuvant chemotherapy they can keep their bladder safely, and another looking at neoadjuvant chemotherapy followed by consolidative radiation, which is a paradigm that has been done but not tested rigorously. So we're kind of using that signature finding to then apply to patients and patient benefit.
So what would be your next step as far as research goes?
So at our trial, so our findings with the biomarker have spawned these 2 clinical trials that are being run, one by Alex Kudikoff at Fox Chase and the other by Dan Geinesman, also at Fox Chase, again looking at bladder preservation. So different ways patients with the use of neoadjuvant chemotherapy can keep their bladder, keep an intact functioning bladder. I think that's the next road with this. From an immunotherapy standpoint, we're also looking at our center at ways to reinvigorate patients' response to immunotherapy. So there's definitely a group of patients who don't respond or respond and then certain clones grow through the immunotherapeutic approach. If we can reverse that or tweak that so that non-responders become responders or that resistant tumors can then be rendered sensitive again, that would be a great benefit. So now that we know what benefits a group of patients, we're immediately looking to the group of patients who don't benefit or don't get enough benefit or lose their benefit. How can we fix that problem? And I think that's the big issue that's now emerging with immunotherapy. We're glad the phase 3 trials are done. We look forward to seeing those results. I'm certain that immunotherapies will be part of our armamentarium very soon. Not soon enough, but very soon. But then they don't work for everybody. So how can we figure out who they're going to help and who they're not going to help? And for that group that they don't help as a single agent or by themselves, is it a combination strategy using radiation, better patient selection, immune priming? All kinds of theories are out there, and a lot of smart people are working on them. So I'm eager to see what that next wave of investigation shows, and we're participating in that as well with some investigator-initiated work.
Now you mentioned combination therapy. Can you give me an overview of what's going on now in that field?
Sure. So combination checkpoint inhibition has been a really hot topic in melanoma and kidney cancer. The data looks very good. It's already approved in melanoma. This is ipilimumab and nivolumab, so CTLA-4 and PD-1 inhibition concurrently. And in kidney cancer, the early data looks good in the phase 3 trial. As you know, we'll read out soon. So I don't know about soon, but we'll read out at some point and we'll see the answer to that. So taking those 2 tumors and the experience with combined checkpoint inhibition, of course, there's interest in doing it in bladder. There are a couple of phase 1 studies that we're looking forward to seeing data on in terms of the efficacy in this particular tumor type. But in addition to dual checkpoint inhibition with CTLA-4, there are a variety of other immuno combinations, immuno-targeted therapy combinations, and then just novel approaches to priming the immune system. We're using interferon gamma, for instance, where we are to sort of prime the PD-1 response. So I think we need lots of smart people thinking about the resistance problem now.
I have 2 more questions, sir. Adverse effects. Can you talk a little bit about that?
Sure. So I think, especially to a urology community, it's really important not to underemphasize them. The way we measure adverse events is with CTCAE criteria, and not just sort of the most severe, sort of the high watermark is what gets recorded. So if you have really bad diarrhea, it's a grade 3 event. Well, if you get on top of it and treat it before it's grade 3, but the patient still needs 3 months of steroids, that's probably also a medically important event. So I think defining toxicity for these immunotherapy trials has been a little bit of a challenge. There are also some things where we turn to CTCAE and they don't adequately describe the severity of what what we're dealing with. So that's one piece of it. We do know that there are autoimmune effects of these drugs. What I tell patients is there are no side effects of these drugs. The intended effect of the drug is to get the immune system to attack, but sometimes it can attack a healthy tissue instead of the tumor. And that can manifest in a wide spectrum of symptoms. So it's not like our targeted therapies or chemotherapy where we kind of can predict if they're going to get side effects, which ones they'll get. With these, it's always a surprise, and it can happen at any time. So it can happen months into therapy. So those are things that make giving these drugs, even though they're benign and well tolerated for the majority of patients, those complications are generally challenging diagnostically and in some cases therapeutically, and so deserve special mention and probably specialization and a specialized focus on how to manage them.
Great.
Yeah.
Now you mentioned your own research, or any data from that available? Can
Yeah,
you
so
share
there's
that
a
with
European
me?
urology paper
Okay.
that we published it came out in August. I think it was EPUB'd in June, came out in August, and that showed our signature. So that's a
Okay.
cool paper, definitely
Okay, I'll definitely highlight
worth
that.
highlighting because it was a validated response.
Great.
Signature.
Did you have anything else you wanted to sort of leave me with?
No,
like
it's
a
good.
2-minute
Thanks for
takeaway?
broadening the topic
Okay,
because my
great.
topic is really
Yeah.
different. Yeah, good.
Great.
Great.
Thanks so much
Thanks
for
for
your
your
time.
patience, and again, I'm sorry.